Hi again, everybody, and welcome back to the next episode of the Dental Implant Podcast. I'm on my break here at Evo Dental, and being the titanium nerd that I am, being the titanium nerds that we all are, I'm going to record the next episode right now for you. So again, sorry it's been a long break. I'm not going to use the same excuse as last time and say, I'm going to use this break as an excuse to launch season 2, because I only did like 2-3 episodes. I've just been busy. I've been flat out, no other excuses. But I am still here. I am still committed to helping you understand implants better. So it doesn't matter what part of your journey you're in, whether you are right at the beginning of your journey, you haven't even started implants, or whether you're partway through and you're starting to find your feet. I even hope that there's some stuff on here for people who are proficient. So this is aimed at being quite diverse. And I'm going to be rambling today about implant failures, what I think causes implant failures. This is something that I've alluded to in the past, that there are so many factors involved in the healing of implants that it's really, really difficult to design a study and say, right, no, we're going to do a randomized control trial. We're going to assess this one aspect and keep everything else the same. It's just not possible. It just does not happen. Okay. So a lot of it is reading between the lines. It's understanding how factors interplay with one another. And that's one of the things that I'm going to go over today. Just to make you aware, I'm not sat here turning around and saying I don't have failures. I absolutely have failures. I've said this before. People who say that they don't have failures and that they have 100% success rate, they are either only placing 1 or 2 implants per year, or they're lying to you. It's one of those two things. Okay. One aspect I'm going to come to in a minute is systemic factors. And Bill, if you're listening to this, do you fancy coming on again so that we can talk about this increase in early failures? Because you know my thoughts on it. I'd love to get your thoughts on it as well. Okay, Bill Schaefer, that is. We all know, awesome guy, and I'd love to chat to you more, Bill. So let me know. Okay, in fact, I'll reach out to you instead of just putting it on the podcast. Right. Okay. So let's break it down into surgical first. So I've got my brief notes here. That's why I keep glancing over for those of you watching on YouTube. So one of the things that can cause implant failure is blunt burrs. We don't think about this enough. Burrs have a finite lifespan, and how long they last depends on which implant system you use. Okay, some implant companies will recommend changing the burrs over once every 10 uses, once every 20 uses. Others will have a certain sequence of burrs which are single use only. It is really, really, really important that you are changing over your burrs regularly. Okay, now I want to quantify that a little bit further. Is if you see a patient where you're doing, let's say, full arch from, and they've got D1, D2 bone everywhere, those burrs are not going to last as long as if you had somebody where you were placing implants where they've got D3, D4 bone everywhere. I had one patient last week did a full arch reconstruction at Evo, and her bone, it was like trying to cut with a hot knife through warm butter. Literally, I'd put the pilot drill would go in, it'd go to length, and I'd just push it, just manual push. And then I'd have the 2mm burr, just push it to length. And then I was putting in a 5mm diameter implant, having opened up the crest a little bit more. I was barely getting 35, 40 Newton centimeters. It was just insane. So we need to respect the type of bone that we're drilling in. We're going to come back to that in one moment, okay? If you do nothing else, change over your most frequently used burrs much more frequently, okay? Particularly your pilot burr, particularly your 2mm twist. Those two, they get used way more often. The rest of them are predominantly for shaping, but those two are your main drilling sequence burrs. So make sure that we're keeping a track of how often you use these burrs and just replace them on a regular basis. If you're in a position where you can charge your patients a little bit extra and you really want to kick things up a notch, is buy a brand new pilot bone for every single implant that you do. A lot of these companies, these burrs, they're not expensive, or not that implant companies like me saying this, you don't have to use their brand. If you know of a decent couple of burrs that are cheap that you can use from wherever, you can use those, and you need to be replacing them frequently so that you have really, really good cutting efficiency. It's down to the cutting efficiency of the burrs, okay? And you can't see when they're wear. Sometimes you need a microscope to look at them to see the amount of wear. Okay, so next one, incorrect osteotomy techniques. Now, I've mentioned this before. 50 Newton centimeters on trabecular bone is different to 50 Newton centimeters on cortical bone. You need to understand the type of bone that you're drilling into and modify your osteotomy accordingly. Okay. When I have very soft bone, is my osteotomy is much more tornado shaped. So it's very narrow at the bottom and it flares up towards the top. Even in super soft bone, I don't want any pressure on the cortical bone, just that 1.5, 2 millimeters in the top. So I'll always prepare that out to length. And there was, I think it was Block et al. Did a study where they showed that if you oversize the neck ever so slightly, listen to what I'm saying, not the entire osteotomy, just the neck. If you oversize the neck ever so slightly by 0.1, 0.2 millimeters, is you get a slight reduction in primary stability, ever so slight, but the integration rate increases and the long-term stability around the neck of the implant is better after 6 and 9 months, okay? So when you hear me talking that I'm hunting for 75, 85, 100, 120 Newton centimeters, you need to understand that I'm qualifying that's not on the cortical bone right at the neck of the implant. That's elsewhere, okay? And if you've got D1, D2 bone, then you want a much more parallel osteotomy where your implant drops almost to the end completely, and then the last 1 or 2 turns, you want to see the primary insertion torque take off through the roof. So all your primary insertion torque comes in from those last 2. So that's how I do my preps for dense bone. And the issue with that is you can easily over-prepare and end up with 0 peak insertion torque. So you really need to have a good handling on how your burrs work, on how your implant body is designed as well, and how your threads are designed. Because it's not just the threads that give you stability, it's the implant body design as well. So understand your osteotomy techniques, okay? The next point I've already discussed, which is the difference between cortical and trabecular bone, okay? I've got no problems putting pressure on trabecular bone. I've got no problems putting pressure on cortical bone when I'm bicortically fixating and it's at the apex, okay? But when you bicortically fixate, it does actually alter the forces that are on the neck of the implant as well. So you need to understand what's going on, okay? So as I said, nice tornado shape for soft bone, pretty much parallel for dense bone, depending on your implant design, okay? So the next one is suturing. You need to have a good suturing technique, not just single interrupteds, although I fully respect that's what most people do nowadays. You need to learn different suturing techniques. You need to, there is a narrow-based, horizontal sling, vertically compressed suture, which I use a lot. There are modified vertical mattress sling sutures, which are really good in aesthetic cases. And additionally, so you need to research more about different suturing techniques. But it's not just that; it's the material itself. Okay, is you want to have something that's pretty smooth. And when you have something that's pretty smooth, such as a monofilament, the tissues just heal way better. Okay, PTFE is superb as well. I use glycolon a lot. Glycolon is absolutely beautiful. The downside to glycolon is it's clear. You can't see it. It's a real nightmare when you're trying to suture it. You're like, where the hell is it? Where's it gone? But the results that you get back are superb. In aesthetic cases, I use 6-0 sutures with a small needle. Don't want a big needle, okay? And in other cases, I aim to stick to 5-0, basically. The only time I ever go 3-0, and I know some people still use 3-0, is when I've done mucoplasty in the upper and I've clipped the artery and the patient's bleeding all over the place. You need a thicker suture to tie off the artery, basically. But look at your different suturing techniques, okay? What's the next one? Not understanding your implant design, okay? Again, this is something that I've alluded to before. If you don't know how your implant works, if you don't know what the macro design of the body's supposed to do, if you don't know what the thread design of the body's supposed to do, if you don't know what the pitch is, if you don't know whether it's a single or dual start thread, if you don't know whether it's a progressive thread, how exactly are you planning on using it? So you need to research your implant system a little bit more. One thing that I really liked is last week on that case with a super soft bone, I ended up using the Southern Max. And the Southern Max it's designed to achieve extremely high primary stability from the macro design of the body, not necessarily the threads. But even using that, on that particular one, I got about 35, 40 Newton centimeters, whereas normally I'd be expecting 80. That's the quality of the bone that I had in that case. So you need to look at your implant designs, okay? Now, I am considering expanding all of this knowledge out into much greater depth and details other than just the podcast. So if you think that you might be interested in a course, like online, something along those lines, let me know, because if you're not interested, I'm not going to do it. I'm not going to waste my time. I'm too busy. But if you are interested, I'd love to be able to share this information more and go into a lot more depth than what we're covering here as well. Okay. Next one, taking too long. There's not a great amount of evidence that, once you raise a flap, it's raised, but all of the very experienced implant surgeons that I speak to, and certainly from my own experience as well, the quicker you're in and out of surgery, the faster the implant will actually heal. But converse as well is, if you haven't been exposed to enough implants, it's going to take you longer to start with as well. You can't rush these cases. You've got to do it quickly, but stay committed. Right. Titanium nerds, stay committed. Okay. Keep exposing yourself to implants. Keep doing it. Keep learning from your mistakes. We all make mistakes. And what you will find is over time, you'll get faster and faster and faster at doing it. Okay. So, there are instances where a patient's from patient into patient out, sometimes it's 10 minutes. If it's a really straightforward immediate placement, or if it's a healed site, it's 10 minutes. But I didn't get to that 8, 9, 10 minutes overnight. It's taken me years and years and years. It's taken me thousands and thousands of implants. So just stick with it, but understand, the better you're prepared going in, and the faster you're in and out, the faster your patient heals as well, anecdotally. Okay, right, what's the next one? Inadequate soft tissue quality and quantity, and we'll throw bone into that as well. So there's a big thing that, don't have enough bone, and dentists will be like, right, you've got to perform a bone grafting. But very few dentists, and not enough dentists, pay enough attention to the quality and quantity of the soft tissue. Thomas Linkevicius has got excellent data that suggests that if you do not have adequate thickness and quality of tissue, that you are going to have bone loss, okay? And sometimes it's as simple as, when you're putting your healing abutment in, put a little bit of mucoderm around the neck and suture over the top of it, and everything heals beautifully, okay? So we need to understand what interplay soft tissue has as well. Do not ignore the soft tissue. Otherwise, you're inviting problems right from the start. Platform switching does not work very well if your soft tissue is inadequate, okay? You can have any type of connection. If your soft tissue is inadequate, then you're going to start to get bone loss, okay? Next one, patient systemic factors. Bill, this is what I want to chat with you about. I think it'd be a good podcast to do. We are seeing an increase in patients with poor quality bone density. We're seeing an increase in a number of early failures coming up. I have my own thoughts that it's like a systemic combination syndrome. Vitamin D, high cholesterol, poor diet, stress levels, improper gut bacteria, poor quality sleep. I think it's all playing together to make patients just systemically more sicker. Not just patients, us as well. If we are not looking after ourselves well enough, we're not going to heal. If we ever have a fracture or whatever, or need to have an operation, I think it's a global pandemic, which is pretty much going around, and it's due to a lazy and unhealthy lifestyle. Okay, let's move on to restorative now. Poor planning and design. If you've just put the implants in, and you see this a lot in the University of Facebook, you go to any group, and in a lot of full arch groups as well, and you see just implants placed in random awful positions. And I saw, I've seen some cases where it's a full arch, and and people are like, oh, look how beautiful these teeth are. You zoom in on the picture, and the prosthesis isn't fitted on some of the multi-units, so it's impassive. They've not shown you a photo of the fit surface, and they refuse to show you a photo of the fit surface because they're like, it doesn't matter. If the fit surface is uncleansable, how exactly is a patient supposed to clean it? So design plays a very, very big role. Now, something I was told not very long ago, which does worry me, is there are some institutions which think, oh, you know what? Once you've planned everything, that's 85% of the work. The actual implant placement in and restoration is easy by comparison. Is it bollocks? No, it's not. Treatment planning is important. You need to understand what you're doing, but don't think that if you know how to treatment plan that you're going to get a successful outcome. You need to have the appropriate surgical skills. Don't let anybody tell you otherwise, okay? Don't let somebody go, don't go on a course or somebody's going to turn around and say to you, we'll show you how to do guided, because once you can do guided, you can do like 80% of cases. No, you can probably do about 5% of cases. And for those guided cases where you're using a tissue punch, what you're doing with the soft tissue. Okay, this really irates me, as you can probably tell, because what they're doing is they're making implants sound way more easy than what they actually are. And why? Because of this, because of money. Okay, you pay them. Okay, you take on all the risks, you take on all the responsibility. You have problems, but it's your fault, not theirs. If you're going to do it, absolutely, I encourage you, but do it properly. Do not be cutting corners. Okay, learn to do this stuff properly. Understand, I've said this before, it's an expensive journey, it's a long journey, it's a painful journey, it's also worth it. Nothing in life is that's worthwhile doing is easy. Okay, so you need to understand that before you book on a course where all of a sudden, oh yeah, we will send you out the guides, we will do the treatment planning. All you've got to do is tissue punch, and if you can do a post crown, then you can place an implant. It's not like that in the slightest. Please, please, please understand, if you're getting you into implants, it's a little bit more intricate than that. Okay. Next one, reusing components. Don't do it. Okay. We've mentioned this before. If you're reusing lab components, if you're reusing pickups, if you're reusing healing abutments, if you're reusing all of this stuff, they wear over time. Most of them are only supposed to be single use anyway, but if they wear over time, you start to introduce small inaccuracies that get translated forward. It's not worth it, okay? And make sure you're using a brand new prosthetic screw for every single case, okay? Next one, not understanding your connection type. Okay, this again is really important. Okay, I don't really care what type of connection type that you use. Okay, but you should be passionate about it, right? You should understand how to use it. Okay, now what I will tell you is external hex works because I've placed thousands and thousands and thousands of them. Okay, I'll also tell you that Morse taper works because I've placed thousands of those. I've placed hundreds and hundreds, if not 1,000, of internal hex as well. They all work, but you need to understand how to use the connection. They've all got their pros and cons. Okay, you need to understand the connection. Any implant company who turns around and says this implant connection is perfect, everything else is useless, they've got an angle. It's that simple. There are some connections which are exceptionally stable long term, but they're much easier to use for single implants than what they are with multiple implants. And how you treat one type of connection, you don't treat a different type of connection the same, because they've all got their minor intricacies. And it's not just that, but even the same similar-ish connection between different systems. That, implant companies, they want to make a minor tweak and try and pretend that this is going to solve all of your problems. And then you've got to have a different feedback from that, if that makes sense. You need to learn how to use that as well. So you need to be consistent in what you're doing, understand how the connection works, and apply it appropriately. Okay. So I see a lot of people applying implant connections inappropriately, find out that they have a problem, and then they blame the implant or they blame the implant connection because they haven't used it correctly. So you need to understand not only your implant body design, your implant thread design, you also need to understand the connection design as well. Really, really critically important, okay? The last one I'm going to cover at the moment is not cleaning your prosthetics properly when they come back. Most people take it out of the lab box, they look at it and they go, oh yeah, that looks nice, and they drop it into cold sterilization for 10 minutes and it's ready to fit. That's not appropriate. You have to properly disinfect your lab components, because the soft tissue reaction is significantly improved when you do that. Okay, so you can see what we've been discussing so far. It's not just one thing. It's not one minor thing. It's a number of different things which are layering together, which can start to tip the balance in our favor or out of our favor. And you need to understand all of this. So get studying, titanium nerds. And I look forward to sharing more again in the future. But as I said, this really is a fantastic field, but I dislike it when people turn around. No, I'm not going to use the word dislike because that's not passionate enough, right? I hate it when people pretend it's easy, right? They're trying to, it's not easy, but it's worth it. But you have to be prepared to put in the correct level of effort to reap the rewards, okay? So, as always, if anybody wants to come out and see us at Evo Dental, get in touch. We'd be more than happy to show you what we do on a daily basis. I've got some more podcasts lined up. I've got loads of guests lined up, but they're sick, I'm sick, or they're busy, I'm busy. Oh, I will try to get these people on board ASAP. If there's anything else that you would like to learn, like to know about, please do let me know, and we'll pick up suggestions from yourself and move forward accordingly. So until the next episode, folks, thank you very much for listening. Encourage your friends and colleagues to listen. You know what? I don't care if they don't listen to implant. They don't. I don't care if they're not even dentists, right? I don't care what they do. Tell them, you know what? Help this guy out. Listen to his podcast. It's all much appreciated. Okay, help spread the word, and I am here to help increase your knowledge. And I hope you've got just a couple of bits out of today's episode. I'll speak to you guys soon. Bye.